second seminar in our Professionalism in Medicine series. This is a series that is endowed by an anonymous donor who will keep the anonymity. And this is the beginning of our two-day celebration at the end of every academic year. The second day will be tomorrow, where all of you, mostly graduating students, will present your capstones, and there will be food, or more food than today supplied. Today there will be food, but not at dinner. Tomorrow there will be food. So welcome all, and especially welcome to the students who we have accepted for our next year's class to come here to see something about what this is about. So we spend a lot of time over your core curriculum talking about medicine in the context of the social contract. And we spend a lot of time talking about whether health care is a right or a privilege. And we spend a reasonable amount of time trying to work out for all of us what is meant by government of the people, by the people, and for the people. And today's speaker is perfectly suited to talk about the issues of healthy Chicago. He is the Commissioner of Health in the city of Chicago, Dr. Bechara, who was trained in Lebanon, first as an undergraduate where he majored in chemistry, and then he did medicine, and then he migrated to Texas. I have yet to ask him whether that was a form of culture shock. But after being immunized and doing all the things you have to do to go from Lebanon to Texas, he finally found truth and migrated here. And he is our Commissioner of Public Health in the city of Chicago. And I welcome him and look forward to hearing about healthy Chicago, progress toward improving health. Thank you.
Thank you. I'd like to see how we can get rid of this. All right. Thank you, everyone, for coming in tonight to spend maybe 45 minutes learning a little bit about healthy Chicago. And then really I'm going to open it up for questions. These conversations are a lot more fun when they're interactive and a lot of back and forth. So my name is Bechara Choucair. I'm a family physician. And just like you mentioned, I went to undergrad at medical school in Beirut, Lebanon, at the American University of Beirut. And at 24, I felt like I was done with medical school. I wanted a new, fun experience. I wanted to travel, do something else. And so I was interviewing for a family medicine residency program across the United States. I applied, actually, for a lot of places, but many of these residency programs are like, who's this guy from Lebanon trying to come and do family medicine here? So I got 4 interviews, and I traveled all the way, and I interviewed in Houston, Texas, Washington, D.C., Cleveland, Ohio, and Charleston, South Carolina. And being never been to the United States before, I went back to Lebanon, and I'm like, I've only seen this white stuff that they eat in the morning in Charleston, something called grits that I've never heard of before. So that's going to be off the table. I like DC, but I really like Baylor College of Medicine. It was a good group of people I got the chance to meet with, and I decided to actually emigrate to the United States, and specifically to Texas. So I was in Texas for 3 years. I did my family medicine residency program in a healthcare for the homeless, in a residency program that was embedded in a healthcare for the homeless program within a federally qualified health center, so a community health center in the northwest side of Houston, serving mostly Mexican immigrants. And once I was done with residency, I really wanted to work within a healthcare for the homeless program. And I interviewed for a bunch of places. I ended up out of every healthcare for the homeless program across the country in Rockford, Illinois. They hired me as the medical director for the healthcare for the homeless program. And that actually, Rockford was my first interactions with the University of Illinois. That's where I got my first academic appointment at the University of Illinois in Rockford. And I was there for 5 years. The first 2 years I was the medical director for the Healthcare for the Homeless program, and then after that I became the medical director for the whole network of federally qualified health centers on the, in Rockford, Illinois. So it was really exciting. I was 27, I was supervising 55 docs, and it was really good. I've learned a lot. Rockford was really good to me. They gave me the opportunity to become a better physician as I was seeing patients, but also a better administrator. And also I got the opportunity to get a master's in healthcare management while I was in Rockford. So I felt like I became a much better physician, but also a better administrator. But I was actually, for the good part of that time, I was living in Chicago and I was commuting back and forth, and I was missing the global health work. And Heartland Alliance, which many of you might be aware of the organization here in Chicago, it's a human rights organization. I ended up being hired as the medical director and the executive director of the Heartland Alliance healthcare arm, which was a network of clinics on the north side of the city, mostly providing services to immigrants and refugees, but also to people experiencing homelessness and people with HIV. And the fun part in my role at Heartland was when I got to do a lot of global health work. So Heartland had programs in Guatemala, and Mexico, and Iraq, and Lebanon, and Jordan, and Sri Lanka, and Nigeria, and many other places. And I had the opportunity to be kind of like the medical consultant for all these programs. And all of it is really looking at human rights issues, and the healthcare lens is one of those lenses that we've applied on all of our interventions during my tenure at Heartland. So it was a great 5 years at Heartland. I was there enjoying what I'm doing. I'm happy with where I'm at until I got a call one day from the mayor's office saying, hey, this health commissioner position is going to be vacant. We're reaching out to people to apply. Would you mind applying? And I've never really thought about working for government. I was really excited in being at Heartland doing the work that I was doing. But I said, sure, I'll apply. And I did apply. They called me for a first interview to City Hall. I went there, then I called me for a second interview with the chief of staff. Then they said, oh, you're one of our finalists, and we'd like you to meet Mayor Daley. And that was towards the end of 2009. I've never met Mayor Daley before. I've met a couple of the aldermen just from my work in Uptown. So I went there, and I'm like going for an interview, anxious, and what is the mayor going to be asking me? So I'm prepping for all these questions. And I go there, and we had a really lovely conversation talking about immigration and why I decided to move across the world and all of that. And he asked me basically no questions about healthcare at all. So that was fun. But then an hour later, I got a call asking me. He asked me to come on board as the health commissioner. This was something I've never thought I'll do. It's a great opportunity to be able to be at the helm of a health department here in the third largest city in the country. A little bit of the background about the health department in Chicago. How many of you are familiar with the health department in Chicago? Not many, just a couple. Okay, so we are actually one of the oldest departments of public health in the country. We were formed back in 1834. It was actually 3 years before even the city was incorporated. And at the time, there was a cholera outbreak, and a group of doctors came together, and they said, oh, we need to do something about this. And that was really the nucleus of creating the Board of Health in Chicago. And the Board of Health was created then, and fast forward almost 80 years now, 178 years or so, we're one of the largest departments of public health in the country. We invest around a little bit less than $200 million every year into the public health system, and we do all kind of work. We do clinical services, we do a lot of policy work, a lot of legislative work, we do a lot of emergency preparedness work. So if there's a bioterrorist attack in Chicago, my department would lead the response to that type of attacks. But if also there are floods, or there are heat waves, or cold waves, and all of that stuff, we respond. Just recently, over the last week, we were responding to the flooding that we've seen in Albany Park and other parts of the city. So we have a lot of work around emergency preparedness, and we just talked about Dr. McKinney, who heads our emergency preparedness team. We work very closely with hospitals around emergency cases, and how do we make sure that the hospital system is still ready to respond. And then we do a lot of education work, a lot of campaign, a lot of media work around health education, but we also do your core public health stuff, and that's lead poisoning, immunization. We do inspect every one of the food establishments in Chicago. There's around 15,000 of them. So anytime you're eating at a restaurant, if you actually go to our website or you actually Google restaurant inspection reports in Chicago, you could check out the restaurant where you're eating, what were the last findings from our last inspections. If you really, really like the restaurant, I won't encourage you to do that. But if you're so-so or if you want to try a place, I definitely encourage you to check it out before you go. So we do a lot of that type of work. So we have a little less than 1,000 employees. We have locations all over the department, all over the city, and we do a lot of good work. So what I'm going to be talking today about is really how do we strategize and how do we define strategy and programmatic interventions and policy interventions to really make a difference in the lives of the 2.7 million residents who live in Chicago. Just a little bit on the background. Back in March of 2010, President Obama signed the Affordable Care Act into law. And in that law, there was a lot of people think about this law mostly around health insurance access, or how do we get more people insured, which is true. But the law has a lot more implications to our healthcare system that didn't get into a lot of the national debate that happened at the time. But it's really redesigning the way we provide healthcare services, but it really also putting a lot of emphasis on public health and prevention. So as part of this law, the president created this council that included the head of so many departments across the government to create this public health and prevention council. And the role of that council at the federal level is to really try to see how do we improve the health of our country overall by looking into transportation, by looking into health services, by looking at agriculture, by looking at education. So really kind of get into this concept that we call law and all policy type of approach. So in addition to the federal interagency council to focus on public health, the president appointed an advisory council on public health and prevention. There are actually two wonderful women from Chicago who sit on that council. Sue Swider, who's a nurse at University of Rush, and Barbara Otto, who's the executive director of Health and Disability Advocates. So this advisory council is really advising the president and this council on what to do around public health. And in June of 2011, that advisory council and the actual council generated or released this national prevention strategy. And in this national prevention strategy, they identified priorities and they said, these are the public health priorities that our country needs to be focusing on. And these are some strategies that we need to be working on at a national level to make a difference and improve the health of our communities. Here in Chicago, we've taken that national prevention strategy and then we've developed the Chicago version of that national prevention strategy. So what would it mean when the federal government say these are the national priorities, these are kind of the recommended strategies? We took this very, very seriously and we worked kind of actually in parallel as they developed the national prevention strategies. We've developed what we call Healthy Chicago. And in Healthy Chicago, we've identified public health priorities and we've identified strategies we're going to be implementing to improve the health of our city. And if you remember, if you lived in Chicago at the time, that's when Mayor Emanuel was elected as the mayor for the city. And I've never met Mayor Emanuel before he was elected. And when he was elected, he re-interviewed all cabinet members, so I have to go and re-interview for my job. And one of the things that we talked about in that very, very first interview was that we wanted to create that Healthy Chicago agenda or that public health agenda and make it public in the first 100 days of his administration. And this was extremely important for so many reasons, but the most important reasons is very early on, the mayor, and you probably have the actual agenda, the mayor stood in the first 100 days of his administration and said, this is my public health agenda. This is my commitments to the residents of Chicago. That those are the priorities, those are the strategies that we're going to be working on, and this is how we're going to be implementing them. And by the way, these are the targets that we want to reach for each one of those priorities by 2016 or 2020, again, for better accountability. So I know some of you are actually looking at the agenda, but one of the things that we've done in the agenda is we've identified 12 public health priorities. So I'm going to challenge you right now. Don't look at the agendas. What do you think those priorities are? And you can shout them out or you can raise your hand. So if you are in my shoes and when I come up with those priorities, what do you think these priorities are? Obesity, that's number one. Other priorities. Tobacco. Oh, you guys are great. You picked up the first top two. Usually people start thinking about other stuff, but tobacco and obesity, those are, in my mind, those are our top two most important public health issues that we have to deal with. Everything else is important, but these, in my mind, you guys got them right away. Tobacco and obesity, number one, number two, very, very important. Maternal child health, so healthy moms and babies. Violence prevention. Access to care. HIV prevention. Did you guys look at those? Like getting them right very quickly.
Public health infrastructure.
Oh, come on, you know you read that. All right, so you have that agenda. So these are so we went through a pretty significant process to identify what those priorities are. We've talked to our internal staff, internal content experts. We brought experts from the community. We talked to folks at UIC and other places. And then we've talked to our partners at the state level and at the federal level, and we've listed those priorities. So that was in August 2011, and I remember, it was a press conference followed by a large meeting with over 300 public health advocates, and we said we're making a commitment that today, on August 16, 2011, we're going to be implementing 193 different strategies along all these priorities to make Chicago a healthier city. And I remember for a moment when I said that, and we've been thinking about it for a while, but the moment I said that in front of the cameras and in front of everybody, I'm like, oh my God, what did I do? It was just this humongous commitment. So today I'm going to give you a snapshot of some of these strategies that we've implemented. So to make it, to kind of let you know, so out of the 193 strategies that we've committed we're going to implement back in August 2011, almost 80-some% of those we've already either completed or in the process of being completed. And the next slides are going to start sharing with you some of these strategies that we've actually implemented to give you a flavor of what those strategies are. I'm not going to go through all the priorities and all the strategies. I'm going to take probably tobacco and obesity alone, and then I'm going to just open it up for questions. By the way, for you, I did send the link on Twitter for the slides, so if you want the slides, or I'll make sure I'll work with Karen to pass along the slides to everybody. All right, so I'm going to start with tobacco. What do you think is the adult smoking rates in Chicago right now? How many people smoke, or what percentage of adults smoke in Chicago? 20. Who said 20? All right. Oh, she got it right. Yes. So we are at 20%. We'd like to be lower than that. Who knows what's the smoking rate in New York City? 10. No. That's 15. 15 point something. Well, now they'd like to say that less than 15. So 14 point something %. So they're slightly less than 15%. What about the smoking rate in California as a state? 10. 12. Less than 12. So the 10 number is actually really important because, if you look at the state of California, that's been the state that's the most progressive on policies around tobacco. Their smoking rate right now is 11.9% compared to ours at 20%. That's like almost half of our smoking rate. And when you look at the rate of lung cancer decline in California, it's declining 4 times faster than anywhere else in the country. So we have a lot to learn from California, from New York. So we were very aggressive in that agenda around policies to really make a difference on tobacco. One key strategy was to create more smoke-free environments. So as you know, you can't smoke in public places. You can't smoke in buildings within 15 feet of a building if it's a public building. So there are the existing state laws and then Chicago-specific smoke-free law, which is pretty strong. But we know we wanted to take this to the next level. So we pushed for a lot smoke-free, more smoke-free environments. And one specific area we focused on is higher education. So we went to these higher education schools and we said, is there a way we can take a smoke-free or maybe a tobacco-free policy for the whole campus? So not just in the buildings, but on the whole campus, including parking lots and all of that, and make sure that there are resources to support smoking cessation efforts for students. So we've worked with many higher education institutions. Our biggest success has been with the City Colleges of Chicago, 120,000 students, 6,000 faculty. All of them right now are working and learning in an environment that's tobacco-free. So all of our City of Chicago colleges now are tobacco-free campuses. We were really excited about that. We also worked with Roosevelt University, and also we worked with, one more. Robert Morris. And then we knew actually all along that University of Illinois was not tobacco-free, and I worked with a group of medical students and from the University of Illinois who worked also with another group of student advocates at the University of Illinois, and I was really, really excited to learn that the University of Illinois now is getting ready to be a tobacco-free campus, which is extremely exciting. And I don't know if any of you are part of the signing the petitions or going to meetings and advocating for this, but we're extremely excited to see the University of Illinois joining other higher education institutions in adopting tobacco-free campuses. And then we went to hospitals. We were like, come on guys, if you're in a place where you're supposed to be providing health, and I don't know how many of you actually, I've come to many of those meetings right around with the university hospitals, and you're walking into this hospital and you'll see so many people with their hospital gowns smoking at the door. So we wanted to make sure so that many of the hospitals adopted tobacco-free policies as well, including Thorac, Norwegian, and other hospitals. And then we went to also mental health institutions or institutions providing behavioral health services. You know, we know that the smoking rate for people with mental illness is a lot higher than the rest of the population. And we know that people with mental illness die at 25 years younger than the rest of the population. And guess what? They don't die from mental illness. They die from heart disease and strokes. So we've worked with 6 behavioral health institutions with 10 different locations across the city, and they've adopted also tobacco-free policies with a lot of support for their participants to get smoking cessation. And then we said, this is nice and dandy, but I think we can do some more. So we went to the Chicago Housing Authorities. The Chicago Housing Authority, there are 55,000 residents in Chicago who depend on the city for housing. So we went to the Chicago Housing Authority, we worked very closely with them, and we've designated 4 out of their 8 or so housing development to be tobacco-free. And again, this is creating an environment where our residents who depend on the city for housing have the option to live in a tobacco-free environment. And we've also hired some of the residents to be peer counselors for people who smoke in the developments who want to quit smoking. So that was another one of our efforts. And we've also, on top of that, we said, okay, this is nice, but maybe also our private apartment complexes, especially in some of the high-rises. Why don't we work with these high-rises or these condo associations and say, can we transform your whole high-rise to become tobacco-free, including the inside of the apartments? And many of the high-rises in downtown Chicago adopted tobacco-free policies, and now residents who live in these high-rises don't have to have the second-hand exposure to smoke because other people in other units are smoking. So we've done a lot of work on creating more and more smoke-free environments. But then we've done some other stuff as well. You know, if you are selling cigarettes, there is a hefty tax that comes on the cigarettes. Do you know why? Well, government likes to get money, but why is it important? Yeah, so it leads to there's a lot of price elasticity on tobacco. So the higher the tax on the pack of cigarette, actually every time you add $1 on the price of the pack of cigarette on tax, there is a corresponding decrease in the sales of tax, and especially it impacts the youth. So we were able in Illinois to get actually 2 bumps into the tax for tobacco last year. $1 on the county tax and $1 on the state tax. And we're hoping that that could save, I think our last projections around 17,000 youth in Chicago alone that won't be picking up their first cigarettes because of those the additional tax that were added to the cost of the cigarettes. But then we said, okay, there are people who are cheating the system. So our friends in Missouri and our friends in Indiana, they don't have nearly as much tax on tobacco, especially the folks in Missouri. I think it's like 17 cents in taxes. In Chicago, it's almost $5 or even more. So what happened was that a lot of these people were actually bringing cigarettes from Missouri and selling them into the Chicago stores illegally and lowering the price of those cigarettes, so more youth would pick up the cigarettes. And the city of Chicago and the county government both have enforcement mechanisms. So we go and check in these corner stores that are selling cigarettes, and we look at the packs of cigarettes, make sure they have the stamps that the right taxes. And if people and businesses are not selling the right cigarettes at the right tax, then they get fined. So we've done two things. One, we've upped our fines significantly in the city of Chicago. At first, it used to be so low that businesses say, if we get taxed, we'll pay $1,000 in taxes and fee and fine, and then it's fine. It's cost of us doing business. So now we've upped that significantly. It's $25 for every pack of cigarette that you see. So that significant increase into the fine, now these business owners have to think twice before selling unstamped cigarettes. And on top of that, we said if there's a city inspector who goes and finds the business in violation of that regulation, then we're going to issue them a city fine and a county fine. And it goes also the same for county inspectors. Again, basically we're more than doubling the fines that these businesses have to pay if they're selling unstamped cigarettes. And we've looked at a couple other things as well. One of the things that you might know or might not know, we used to allow vending machines for tobacco in Chicago. And I had no idea, I've never actually seen one. They're only in a few places in the city, so we banned those. The last thing, we have enough unhealthy items being sold out of vending machines. The last thing we want is vending machines to selling cigarettes. So a lot of work around tobacco. We are expecting to get our most recent survey results to see what percentage of our adults are still smokers, and we're hoping that that number will be less than 20%. So hopefully we'll know about that sooner. So the next priority I'm going to talk about is around obesity. And a lot of time when you think about obesity, the first thing that comes to mind is what? The what? Fast food. But like from a response perspective, exercise more and eat less, and then you're going to lose weight. So it's the personal responsibility issue. And this personal responsibility is very, very important. We want residents to be more thoughtful about what they eat, more thoughtful about their exercise. But the reality is we have to change the environment around our residents so that it's a lot easier for our residents to do the right thing. So one of the things that we've done around physical activity is we're creating more bike lanes throughout the city. And you'll look at over the last year or so, we've created 27 miles of protected bike lanes in the city of Chicago. More protected bike lanes than any other city across the country. 27 miles of protected bike lanes. How many of you have actually biked in one of those protected bike lanes? I did. 1, 2, 3, 4, good. Well, our goal is to get more, but that's a very good start. So we wanted to make sure that we're creating an environment where our residents could hop on their bike and literally bike safely and comfortably in these bike lanes. We've also made 7 bridges bike friendly. And then we've installed 500 new bike racks over the last year. And then starting this June, you're going to start seeing something called the bike sharing program. How many of you have heard of the bike sharing program? A lot of people. Okay, that's good. So in that bike sharing program, what we're doing is we're going to have 300 bike stations and 3,000 bikes by this summer that will be available for our residents to complement their commute and make biking as part of their day-to-day routine. You're going to get a card, you'll pay for it, an annual fee, I think it's $70 or something like that, but it gives you unlimited runs on those bikes, 30 minutes or less. So you could, in theory, if you live somewhere in a different neighborhood, hop on the train, come downtown, you still need a mile or 2 miles for your commute, hop on one of those bikes, drop it in your destination, that's within your 30 minutes, and then you won't have to pay anything for that. So we're trying to create, and then by next year we're going to have 4,000 bikes available for our residents, and we just finished taking input from the community as where the community would like these bike stations to be. So we're really, really excited about that. We've done a lot of work around biking. You know, the other piece, how many of you have actually been to the Dearborn Street in the heart of the Loop in Chicago? Just, you know, have you seen the new bike lanes there? So what we've done there, and we've done something that no other city have done in a long, long time. We took a major street in the heart of the business district, and we said, we're gonna take one lane and turn of car traffic and turn it into a two-way lane for bikes. This is a big decision when you take a street in the heart of your business district. And the message there is that we want the commuters, whether they're commuting by car, by public transportation, or by bike, or walking, to feel safe. Those streets are for everybody. They're for bikers, for walkers, for car drivers, and for people using them, you know, for buses. So we've made a lot of changes to that environment to create an environment that's more friendly for physical activity. The other thing I want to talk about is access to healthy and affordable food. I think everybody's familiar with the concept of food deserts and all of that. So one of the strategies that we've worked on is making sure that mainstream grocers are coming to the city and opening up in some of these food desert areas. But to get us there, it's going to take a few years. So one of the other strategies that we've done is like, okay, can we work with on ensuring that there is push carts or these kiosks that are selling fresh fruit and vegetables throughout the city, mostly in food desert areas. And we created an ordinance through City Council that allowed that. And now we have 13 of those up and running. We expect to have 30 by this spring, and they're all, you know, kind of up in different parts of the community. I don't know how many of you have seen those. They sell fresh fruit and vegetables only. They don't sell any unhealthy items. They're priced appropriately. They take link cards and food stamps so that people who depend on food stamps for food, they have access to be able to purchase fresh fruit and vegetables. But the most important part of that initiative is that it took people who are very difficult to hire. The people who run these carts are people who are just getting out of homelessness or people just getting out of jail. These are difficult people who are very difficult to hire. So we work with them, we train them, and they become small business owners. So it's that intersection between public health and economic development that's really at the core of this intervention. Here's a list of some other initiatives around access to healthy and affordable food or around obesity. So you'll see here we've started 5 new farmers markets, all on the west side, all in food desert areas, all of them accept link cards and food stamps. We're really excited about those. And we've also created a program for people who are using food stamps to actually double the dollar amount on their food stamps up to $10, I think, or $15 if they use those food stamps to purchase fresh fruit and vegetables. Again, we want to stretch those dollars to make sure that they're using fresh fruit and vegetables. We also work on mainstream grocers, you know, the Jewel, Wasco, and the Dominick's and the Aldi's and others. And we've made commitments. We got commitment from 17 or so new stores in food deserts in the city. The mayor personally was engaged in this. We had the First Lady a couple of times in Chicago talking about the importance of this. So it was a great initiative. I don't know how many of you go to Walgreens. You've probably seen Walgreens now selling fresh fruit and vegetables. This initiative actually that's now national. All the Walgreens across the country now are selling fresh fruit and vegetables. It started right here in Chicago on the south side in neighborhoods that don't have access to fresh fruit and vegetables. So again, working with these mainstream grocers to make a difference is something we're really excited about. And then we passed an ordinance actually that allows more flexibility for urban agriculture. We have a lot of land in the city, especially on the south side and the west side, that's not used. Now we've created a lot of flexibility for businesses to do urban agriculture. And actually earlier today, the mayor announced a new organic farm in Inglewood that's, I think it's 9 acres or so, that's producing organic fresh fruit and vegetables right in the community, creating 90 jobs. Again, it's that intersection between public health and economic development. And one of the most fun things that we've done we've pushed for healthier vending. So if you go to the vending machines, I don't know how many times you've seen this sugary drinks and the unhealthy snacks. And one of the things that we've done, we've taken all of our vending machines in the city and we've transitioned them to sell healthier snacks, healthier beverages. We've taken all the unhealthy items from the park districts and it's only selling healthier snacks. We've taken all the vending machines from elementary school and we're only allowing the sales of healthy items in our high schools. So a lot of work around healthy vending. And just last month, we had a new initiative where we asked the private sector to join us in adopting healthier vending standards in their own vending machines. And we had many organizations from Weiss Hospital, Blue Cross Blue Shield, YMCA, and others who adopted those standards. So it's a lot of work that's happened over the last year and a half or so around tobacco and obesity. Let me see what time it is. So it is. It's 5:15. So I'm going to stop here and then really kind of have a conversation with you guys. One, to hear your reflections on what you've heard, and see if you want to talk about anything else. If you go through the slides that Karen will pass along, so there's more stuff about heart disease and stroke, and there's a lot of stuff about HIV, so you can follow that. There are links to some of the HIV reports that we've just issued recently. If you have an interest in HIV and STI, I recommend that you check those out. There's a lot of work around schools, and if you are interested in this, we'll be happy to kind of have that as part of the conversation back and forth. So a lot of stuff around disparities, cancer disparities, specifically around breast cancer disparities, the access to care. There's a lot of work that's happening in access to care, whether vision or oral health services at the schools, all are important. This is around healthy moms and babies. There's a new initiative to make sure that we're encouraging the initiation of breastfeeding right when a mom delivers at the hospital. So a lot of work around that. Also around teen birth rates and teen pregnancy. A lot of work around immunizations and flu vaccines. One of the cool things that we've done last year that got a lot of national attention is we developed an app with the help of some of the Code for America, kind of like some of the Teach for America. There's a group that does Code for America. And they developed an app that if you launch it, it knows exactly where you are using the GPS system, and it gives you directions either by car, walking, train, public transportation, to the nearest location that's offering free flu vaccines, including the hours of operations and all of that. So it was a fun app that we've developed. A lot of people in Chicago used it, and when the flu epidemic was at its peak, this became this big hit, and people in the city of Philadelphia, the city of Boston, and a couple of other cities adopted that same app and then adapted it to their cities. So a lot of work there. So I'm going to stop. One last thing before I stop. So when we developed Healthy Chicago, we've looked at overall strategies, things that improve the health of the city overall. But we knew there are specific populations who need very specific strategies to make a difference. So we've worked with the LGBT community on developing a healthy LGBT Chicago. So what are the types of strategies we need to implement to close the healthcare disparities between the LGBT community and the general community in Chicago? We've also focused on LGBT youth, so this group needs a specific sets of strategies. We've also worked on oral health, so there's a specific plan on oral health. And we continue to focus on specific populations to make a difference. This slide basically shows all of our partners that we've worked with, or most of our partners that we've worked with to help us achieve those strategies and implement those strategies. Government alone cannot do that. Government alone cannot improve the health of the populations. We have to partner with all kind of partners, and this is a snapshot of the partners that we've worked with over the last couple of years. So I'm going to stop here. Here are all the ways you can get a hold of us. We love it when people interact with us on social media. We have a very active social media team. So if you ever tweet us or send something to our Facebook and you don't hear back from our social media team, please let me know. I know we've been very, very active, and I keep an eye on it regularly. So I'm going to stop here and then kind of open it up for conversations. reflections, questions?
Yeah, so there's currently a bill in Minnesota being proposed for an excise tax on junk food, and many studies show that price is the major factor in deciding what food to buy. So are there any discussions that this issue on that?
No, we're not right now. We're not talking about an excise tax on junk food. We're really focusing on availability of junk food. So we've looked at our policies on what we're selling in vending machines. We pulled all vending machines from schools, so kids don't have, students at CPS don't have access to unhealthy items. So it's mostly we're working around access issues. We haven't discussed yet, taxes around junk food. Yes.
When working with universities and hospitals, what was the major hurdle in getting those?
It was a lot harder than what you think. We heard all kind of different reasons. One of the reasons was like, well, if we have employees who don't want to quit smoking, even though we promised we make smoking cessation resources available, nicotine patches, counseling, whatever it takes. They said, well, if they choose to continue to smoke, that means this employee, if that employee, he or she wants to smoke, have to get out of their office or desk, go to their car, if they have to leave the campus, because remember, the parking lot is also campus tobacco free, get in their car, get out of the campus totally, to be able to smoke and come back and get back to the office. So there was all kind of productivity issues, there were concerns about, unfair to people who are smokers, all kind of stuff. But most of these issues were resolved as we worked with the attorneys and most of these institutions had to put committees to review things and survey people and come up with recommendations. So it's not easy, but most of those hurdles really could be reduced. Yes.
First, I would just like to say thank you for all the work you and your departments do in the city of Chicago. I had just one quick question. How do you? I know you were saying that you take out cigarettes from vending machines or you take out junk foods from vending machines. How can you, I guess, combat the incorporation of that kind of these specific products?
So it's not easy, and there are different ways to address that. I think from a policy perspective or from environment perspective, we have many initiatives that we're working with the industry to really make healthier products. One of these initiatives that health departments across the country, including the Chicago Department of Public Health, is working on is the reduction of salt content in some of this prepackaged food. And we have a pretty deliberate, extensive initiative where we're working with the industry to make sure that they're making commitments to reduce the content in sodium. I mean, I don't know how many of you are thoughtful about, kind of looking at the products you're buying and looking at the content of sodium in them. A friend of mine was just recently diagnosed with high blood pressure, so I'm like, I'm going to be more thoughtful about it. And I buy most of my stuff from Trader Joe's, and there's this one, kind of eggplant spread that they have, and I, buy it, eat it, not pay attention to it, and I'm looking at it. This one container that you could really eat in maybe 2 servings in it. In one serving, it has almost as much sodium that you need in a whole day. And this is just the spread alone. This is not talking about the crackers and all that. So I mean, we have to engage the industry to really lower the content of sodium that they have. We kind of have conversations with PepsiCo around some of their products, and PepsiCo has made a commitment that they want to grow what they call the good for you food versus the fun for you food type of portfolio, and they're growing that portfolio a lot faster. So we have to engage the businesses. Some will tell you we don't need to engage them, we just need to fight them. Some would say we only need to work with them. The reality is we have to kind of build partnerships, but at the same time, make sure that we have the right to regulate some of this stuff and not be shy about saying, well, this stuff needs to be regulated to be able to do that. So I think it's a combination of both. And that's what we're doing in Chicago. It's really a combination of both. Yes?
So identified all these really specific ways for health. But I was wondering if you could talk more about the intersections between them. Like, for example, the ABC prevention day, how you can see that's something that's probably very much linked to violence prevention, the environment that you're in, feel safe enough to go out and exercise. So I was wondering if you could just talk about the intersections in terms of like the Chicago
So this is an excellent question. So how do we, I mean, really this separation of the priorities into 12 and these strategies into 193, it's more of an artificial separation just to make it easier for us from an accountability perspective. But a lot of these initiatives are really interlinked. And I'll give you specifically the example that you've asked about, this obesity and violence prevention. So one of our strategies was to create something called place treats. How many of you are familiar with the concept of place treats? Just a couple? Just out of curiosity, how did you hear about it?
Just to see, for example, when they shut down the streets and little bit of things.
Yeah, how did you hear about it?
I was just really interested in this kind of thing.
Yeah, so the Play Street concept, and actually was a medical student who took a year off between her 3rd year and 4th year of medical school, and she came and she spent it with me at the health department. She's like, hey, I want to spend a year learning more about public health and you know, just would you work with me? Would you be okay if I spent time with you? So I was like, great. So we worked on, I said, what do you want to do? And she's like, well, I'm interested in literally obesity and violence prevention. So we said, okay, go ahead and research all kind of options that are available that address both of these priorities and come up with a proposal. So she went and researched all kind of different ideas, and she came in, presented to our executive team, and we ended up choosing Play Streets as a concept. So Place Streets is basically, we identified what we've done in this initiative. We identified 6 neighborhoods in Chicago that have the least amount of green space or play lots for kids. And we've identified very specific streets in those neighborhoods. We've blocked them for car traffic for 3 hours, the same day of the week, every week, and then we make that basically a play lot with jumping castles, basketball courts. You know, we have our van that's doing immunization, we have cooking classes. There's actually going to be one on Friday, and I think one of the TV stations will be covering it. And the way we chose the streets, so not only this was an environment to create better physical activity, but the way we chose the streets was very thoughtful, because we worked with the police department to see where are the streets that are most impacted by violence in those 6 neighborhoods. And we chose streets specifically that had violence issues. And I remember the first day we had like the ribbon cutting, the first Play Street event last year was on a street that a week before there were 2 shootings on that street. And so you create that environment where you have all of a sudden 100 kids and their family playing and, you know, and enjoying the day and doing physical activity. And when we did the evaluation, one of the key findings that we found when we interviewed people who participated in these events, they said we felt safer being outside in the neighborhood. And to me, this was one of the key outcomes that I wanted to achieve. It's really linking obesity efforts, but really kind of bringing the violence prevention together. So that's one specific example. It actually started with a student who volunteered for a year with me, but it's the people who are working on this are not just the health department or community engagement team, but 2 community-based organizations who we fund to actually make that happen. And Blue Cross Blue Shield was the sole funder for this project. Does that make sense? Yes.
How do you address the fact that there's more social stigma around weight loss than there is about tobacco cessation? How does that factor into how you approach those 2 targets?
Yeah, so I've done a lot of readings on how in public health we approach tobacco and how we're now approaching obesity. And you'll see it's a very similar approach. It's just there are like a 30 to 40 year difference in between. So some of the strategies that worked very, very early on tobacco, we're seeing right now working. You know, we're starting to work on those strategies on obesity. If you look at the business side, the way the industry is responding to our obesity efforts today is very, very similar to the way tobacco industry responded to the public health efforts back in the 60s and 70s. So there's a lot of similarities, but they're at 2 different stages on that continuum. So I think we're going to get there. We're going to get there faster, where both will be addressed in a very similar fashion. We've actually started thinking about this a little bit in our efforts with corner stores, or in our efforts with reaching out to the communities and the housing authorities or in other environments to really talk about tobacco and obesity in the same way. So it's kind of equalized the stigma that comes with either. Yes?
I think that the intention is to do that medications are laudable, but I was just wondering how you counter the opposition to having that.
Yeah, so this is the nanny statism, basically. every time we say, let's do something, you're going to have the people who believe in personal responsibility as the only solution to all of our public health problems. They're going to say, well, this is, you're being a nanny state and you're like getting into the business of individual people's rights and all of that. The reality is, if you think about it, why does government exist? Government exists to address problems that individuals cannot address them on their own. And it's that collective effort of government's approach to deal with problems that individuals can't be able to solve alone. That's why government exists from the get-go. So if you take that approach, you change the environment. You're not necessarily forcing people what to eat. If you want to eat unhealthy items that's not in the vending machine, you can go to Joe Lasco and buy it from there, and feel free to eat it. But if we are in city building offering these vending machines, I'm not comfortable with offering unhealthy items for people. I want to give them the healthier choice. If they choose to eat something that's not healthy, they're most welcome to do that. They're just not going to buy it from our vending machine. So it's a gray line. There's always a push between the nanny statism and really the individual rights. And at the end of the day, it's a combination of both. It's really the individual responsibility, but if we don't change the environment and create systems where the healthier choice are the choices of default, we're not doing our job as a government.
So this has been a terrific view of what you're doing. I have a question, and that is, how are you engaging the academic community and the medical community in these efforts?
So a couple of quick examples of how we're doing that. I'm going to first talk about how we're engaging students, and then I'm going to talk about how we're engaging medical systems, and I'm glad that Terry's actually here. Perfect timing for that question. So first on students. One, I'm a strong believer that students have a very, very strong voice, and if we work closely with students, we can make a big difference. So when I was first appointed, I said I'm going to invite students from the 5 medical schools in Chicago and see if they're interested in creating a Students for Healthy Chicago committee, and see if they work with me on different concepts around policy and systems change. And we put out the call, and I thought I'm going to get, like maybe 5 or 10 applications. We got over 100 applications. So we had to go through screening those applications and rank them and all of that. So we invited 5 medical students from every medical school in Chicago, and we've worked with them over the last 2 years to really look into actually healthy vending and tobacco-free campus policies. Those were the 2 topics that they've worked on. So in last year, I've realized that medical students are great in kind of bringing the health aspect, but the people that I work with the most at the health department are lawyers. And to change policy and draft ordinances, I really needed lawyers to get me out of trouble, but really to kind of make things move along. So we've added law students this year, and now we have, in addition to medical students, we have law students from I think 3 or 4 law schools. And then we know that any time we're trying to sell a concept, we needed like somebody to market it and package it and sell it to us. So we added journalism students to the mix. And now this group, the Students for Healthy Chicago, is working on a very specific policy change that I'm not going to announce here, but hopefully soon will make a difference. But then with the academic centers also, one example is Terry and I. Terry, I think many of you might know you here. He's the chair of the emergency department here at the University of Illinois. Him and I met a couple of years ago, and we talked about how can the health department and emergency departments work together on ways to improve the health of the public. And we've kind of floated different ideas. And last week, I was, invited here to the University of Illinois when Terry and his team's gotten an award to really look at, it's called EPIC, to really look at, did I mess up the name? No, EPIC. So look into emergency room, multiple people who come to the emergency room multiple times and try to find a care coordination model for them to make sure that they are getting the services that they need to prevent emergency room visits. So those type of relationships, we have many of those with different academic institutions right now.
So in the actual provision of medical care in terms of public health, I would say where the rubber meets the road. Community engagement clinics for hypertension and so forth, which used to be the hallmark of the public health establishment or city-wide public health establishment. Is that over?
No, it's not actually. So, and also a couple of weeks, I would say now, in the first week of April, we've announced a new initiative with the Northwestern Department of Preventive Medicine. So what we're doing in this initiative, and it's fully funded by the GE Foundation, we've identified 2 neighborhoods in Chicago that have the highest rates of mortality and morbidity from cardiovascular disease. And we've designed an intervention that will be administered by Northwestern medical students, PA students, and residents that will actually go to these communities and do mass screenings. We've made a commitment to screen, I think, 5,000 residents in those 2 communities and try to identify people who screen positives for risk factors for cardiovascular disease and make sure we're linking them to care. So this type of initiative has actually got a lot of national coverage just because it's we're going to be using apps and we're having students and doing a lot of different. So it's a lot of innovative ways to linking people to care, and we can't do it without engaging academic centers.
Okay, so you presented us with an interesting challenge, and we liked you. And the challenge that you presented us in the city of Chicago and the state of Illinois is to thank you for your presence here and be ethical at the same time. So we thought about this. We didn't use as big a committee as some of yours, but we did have 3 people thinking I being one of the 3. So we would like to present you with a GPPA medicine mug.
And I'm hoping it's less than $25 because that's the maximum limit of any gift I can take.
And besides which, wholesale prices.
Yeah, that's good.
And finally, so you can deal with biking, you can wear this while you bike.
Sounds good.
Thank you very much for bringing me. That doesn't go